So what is the answer for this first question? If the baby does not begin breathing in response to stimulation, you should assume that the baby is in what apnea? Whether it is primary apnea, whether it is secondary apnea, whether it is terminal apnea, or none of the above. So once the baby is born, so you will ask 3 questions: term, tone, breathing, or crying. Baby has not taken breath. And after that, you will cut the cord and you will bring the baby to the warmer. You will do initial steps. You will do stimulation. You will provide warmth, dry, stimulate, open airway, and still the baby doesn't breathe. So after that, what is that? Well, obviously, baby is in apnea. So what kind of apnea? Whether it is primary apnea or secondary apnea. You can answer in the chat box, each one of you. Only 2 of you are there. So it is usually the answer is secondary apnea. Okay. The baby is in secondary apnea. So any apnea in the baby, you should understand that the baby is currently in secondary apnea and baby needs extensive resuscitation. What is primary apnea? Primary apnea occurs when the baby initially has abnormal placental circulation, when the baby has cord compression or anything. So that time baby will start having gasping breaths. So baby will have few gasping breaths, and subsequently after few breaths, the baby will again have apnea, and subsequently again he will develop some breathing, and after few taking last breath, baby will go into permanent cessation of breathing. So whenever you get any baby in apnea, you should understand that the baby is in secondary apnea, irrespective of whether it is in early cord compression or late cord compression, whatever is it. So you have to assume that the baby is in secondary apnea. Primary apnea, if the baby is in primary apnea, he will need only stimulation. He will immediately cry after stimulation. So those babies who have just minor placental compression or placental abruption, if you deliver immediately, they will be having slight apnea time. So within less than 20 minutes or 15 minutes, so they will just start crying once you do primary stimulation only. So those babies are in primary apnea. And those babies who are secondary apnea, they will have longer time. They will not cry even for stimulation. They require bag and mask and all other such things. So irrespective of whether you know what happened inside uterus, you will never know. So any baby who doesn't cry at birth, you have to assume that the baby is in secondary apnea. Okay. So which device should be readily available as a backup whenever resuscitation may be needed in case of a compressed gas source fails? So what is that compressed gas source? Your oxygen. Your oxygen is not there. So which device you need as a backup? Whether it is a self-inflating bag, whether it is a flow inflating bag, T-piece resuscitator, all of the above. So which one do you have? Always should have a backup when your oxygen source fails. What is the answer? So self-inflating bag. Okay, that is the right answer, Sarah. So self-inflating bag is nothing but AMBU. That doesn't require any oxygen. Okay, so that doesn't require any oxygen. Both T-piece resuscitator and flow inflating bag, they both require oxygen source. Okay, we will come to those devices later. So during chest compression, where should the pressure be applied? Whether it is lower 1/3 of sternum, upper 1/3 of sternum, just over xiphoid process, or any of the above sites are acceptable. Where you want to apply pressure while doing chest compression? Can you type the answer? Where you want to apply? So lower 1/3 of sternum. Okay, that is correct answer. So you have to apply. So you have to draw an imaginary line in the internipple region. So below that line will be your lower third of the sternum. Okay. And how many fingers you have to use? 2 finger or 2 thumb technique? Which you have to use? You have to use always 2 thumb and encircling technique. Okay. So next is, during resuscitation of a newborn, you have established adequate ventilation with an endotracheal tube, and your colleague has begun chest compression for a heart rate of less than 60 beats per minute. So after 60 seconds of chest compression, the heart rate has not increased. So it is still 60 beats per minute. So after 2 times 60, 60 and 60. Okay, so what is the next step? What is the next step after 60? 2 times 60, it is epinephrine. Okay, that is good. So that is correct answer. So you don't you discontinue chest compression. It is not there. So that is not the thing. You have to continue resuscitation up to 20 minutes, not just 10 minutes. You have to continue resuscitation up to 20 minutes. And after 20 minutes also, you have to take a call, individualize. You have to talk to the parents and then decide, not just stop resuscitation. Okay. So air that leaks from inside the lungs and collect in the pleural space, what is it called? Whether it is called pulmonary edema, whether it is called pericardial effusion, whether it is called pneumothorax, whether it is called diaphragmatic hernia. What is the answer? So it is pneumothorax. So pericardial pneumopericardium is if the air is collected between the parietal and visceral pericardium. That is pericardial effusion. So if pneumothorax occurs and it causes significant distress, you have to relieve it by placing a percutaneous or needle into pleural space and evacuate the air. So is it true or false? So it is always true. If it causes respiratory distress, you have to rule it. You have to decompress it. Otherwise, only a large pneumothorax you have to need decompress. Otherwise, a smaller pneumothorax, a minimal just column of air. If it is not causing any respiratory distress, just you have done X-ray for some other reason, for some clavicular fracture or any other reason, you have picked up a small pneumothorax, you should not do a needle puncture or a percutaneous catheter. There is no need to place. It will subsequently absorb on its own. Okay. So what happens if you place an endotracheal tube too far into the trachea? So where does it go into? Whether it goes into left upper lobe, right mainstem bronchus, or left mainstem bronchus. So where does it go? So it is right mainstem bronchus, because right mainstem bronchus is in continuity with the trachea. Okay. So if you don't know the exact length, if you just push the ET tube inside, because you are very enthusiastic and you have established within between vocal cords, you will invariably end up within right mainstem bronchus. Okay. So pulmonary hypoplasia is most commonly caused by which of the following conditions? So which of the following conditions pulmonary hypoplasia is more common? Whether it is due to severe oligohydramnios, whether it is due to congenital pneumonia, whether maternal narcotic use, or cystic hygroma. So which of the following will cause pulmonary hypoplasia? It is very simple. You have to answer. So it is usually severe oligohydramnios. Okay. You need adequate amount of fluid to allow branching of the alveoli, or even the bronchi or second generation, third generation bronchi. Okay. So you need adequate amount of amniotic fluid, so that the amniotic fluid by its pressure, so it will cause the branching of your bronchi, first generation bronchi, second generation bronchi, third generation bronchi, and alveoli. And for lung growth, your amniotic fluid is required. So what happens in your Potter sequence? So Potter sequence, if you remember, you will be able to answer this question. Okay. So what happens in Potter sequence? There will be renal anomaly, congenital bilateral renal agenesis will be there, because of which there will be no amniotic fluid production, no fetal urine production, and fetal urine almost contributes to more than 40% of your amniotic fluid. So if there is no oligohydramnios, so it will cause pulmonary hypoplasia. Okay. So it will cause oligohydramnios and it will cause pulmonary hypoplasia. And it will cause oligohydramnios will cause compression of the fetus between the uterine wall, we will have classic Potter faces, flattened face, depressed nose, okay, flat prominent forehead. So all these things are Potter sequence. So what is the targeted pre-ductal saturation at 5 minutes after birth? So what is the targeted saturation at 5 minutes after birth? So when will be 90 to 95%? We know 10 minutes. So before that, okay, 85 to, how much is it? 80 to 85%. Okay, that is the correct answer. 80 to 85% is the correct answer. So the pulmonary blood vessels in babies who are hypoxemic and or acidemic around the time of birth remain constricted. So what is this condition called? The pulmonary blood vessels will not open up. So what is this condition called? Whether it is called pulmonary fibrosis, whether it is called pulmonary hypertension, whether it is called congenital diaphragmatic hernia, whether it is pulmonary hypoplasia. So what is it called? So it is PPHN. So okay, persistent pulmonary hypertension. So answer is B. Okay. So persistent pulmonary hypertension. So what happens inside uterine, in the intrauterine time, the blood vessels are constricted. So that's why there will be hypertension. Normally there will be hypertension. This right side pressure will be more. So after birth, what happens when the baby breathes, there will be oxygenation of lungs, and there will be cutting of placenta will cause increased left side circulation. Left side blood pressure will be more. Okay, so the pressure will fall. The pulmonary pressure will fall. If there is any hypoxemia, if the baby doesn't take breath properly, the baby continues to remain hypoxemic and acidemic. So those blood vessels will not dilate. That is called persistent pulmonary hypertension of newborn. Okay. So these are some of the important questions we will discuss now, mainly from the book. So some of the important questions are there in the book. So yesterday I told you about the percentage of babies who require resuscitation. That is 85% will begin breathing. Okay. And additional 10% will begin breathing in response to drying and stimulation, your initial steps. Okay. And 5% of them may receive positive pressure ventilation. 2% will be intubated, and 1 to 3 per thousand, or 0.1 to 0.3 per thousand will receive chest compression and emergency medications. Okay. The chest compression and emergency medication, both you should continue same. You should common them. Okay. So next, coming to, we'll brush through this entire thing very fast. What is the most important step in neonatal resuscitation? Whether it is due to whether it is drying, whether it is attaching probe, whether it is chest compression, whether it intubation. No. What is the most important thing is effective ventilation. Giving effective ventilation is your most important step in resuscitation. You should never forget this. Even if you get a baby with 0 heart rate at birth, you have to do bag and mask ventilation only. Okay. So this is about fetal circulation. So fetal circulation and transition circulation, we can do one more time. We can do transition circulation. I have a module for that also. So we will decide it. So fetal lung, there will be fluid. This fluid, it is derived from the amniotic fluid. So this fluid is required for growth of the alveoli and lungs. If the fluid is not there, then there will be lung hypoplasia. Where fluid will not be there, it is in oligohydramnios. Okay. So once the baby takes first breath, so the fluid is all replaced by air. So it will take some time for fluid to displace and get collected by air. If fluid only remains in the alveoli, that is called transient tachypnea of newborn, TTNB. If fluid itself remains. Okay. So these are the blood vessels. See, can you see the constricted blood vessels? This is in the fetus. Fetus, it is filled with fluid and constricted blood vessels. So that is normally constricted. So after birth, fluid should be replaced by air in the alveoli, and these blood vessels are dilated around the alveoli. You can see this. If they don't dilate like this, then it is called pulmonary hypertension. So if the fluid doesn't go out of this, then it is called transient tachypnea of newborn. If the fluid remains within the alveoli, then it is called transient tachypnea of newborn. If the fluid goes away, still the blood vessels are not dilated because of hypoxemia or acidemia, acidosis the baby has, intrauterine severe compression, so many, the cesarean has been done late, or the baby has been in asphyxia for long time, then obviously the blood vessels will be constricted. Okay, that is PPHN. So in that baby, you will invariably expect PPHN. So these are the transition circulation. What happens? Three things happen. Okay, once the baby breathes, air-filled lung will be replaced by fluid-filled lung will be replaced by alveoli. Then your ductus arteriosus will close, foramen ovale will close, and your ductus venosus will also close. So these are the three to four things are very important. Well, the lung will be fluid-filled, the lung will be replaced by air-filled lungs, closing of the ductus arteriosus, closing of the foramen ovale, that is functional closure, and there will be ductus venosus will also close. Okay. So this is the algorithm which we have already discussed yesterday. See, 2 times 60, 2 times, you go with epinephrine. Okay. So if third time also, if they give 60, then go for volume replacement, that is bolus, and consider needling of the pneumothorax. Okay. So 2 times 60, you go for epinephrine. If third time also 60, you go for bolus with your hypovolemia, considering NS bolus, and also you rule out pneumothorax. Okay, you may require needling. Okay, so 2 times 100, you have to go for usually ventilation correction steps. We'll come that we'll revise that again and again. So there are some questions. So what is you can answer this. Before birth, the alveoli in the fetal lungs are filled with what? Whether fluid or air. Whether there will be fluid or air, definitely it will be fluid. So before birth, oxygen is supplied to the fetus by the placenta, not the fetal lungs. Fetal lungs have nothing to do with oxygen. Okay. So before birth, most fetal blood, whether it enters the lungs or bypasses the lungs. So it bypasses the lungs. Only around 10% of your cardiac output will go through the fetal lungs. Otherwise, everything else, it bypasses the fetal lungs. Okay. So after birth, alveoli causes vessels in the baby's lungs to constrict or relax. So it will relax. Okay. So after birth, the air in the alveoli will causes the baby's vessels in the babies to relax. Okay. So when resuscitating newborns, chest compression or medication are rarely required or frequently required. So it is rarely required. Only 0.1 to 0.3%. That is 1 to 3 per 1,000. So it is not. So you can get any of these statements in your options. So you should know everything in detail. Okay, you may get 1 or 2 questions definitely from resuscitation. Okay, so when resuscitating newborns, chest compression and medications are very rarely required. Okay. And members of the team, they should work quietly or share information. They should share information. What is happening with the baby? What is going on in the resuscitation? They have to talk loudly during resuscitation. Okay. So these statements you can get in your exams only. So that's why I wanted to share this. So we'll discuss only the questions. So I will show you one more video, which is the skin to skin contact. What is skin to skin contact?
Oh, it's come out now. Baby's coming out now.
So baby is born. So where do they put the baby? They have not cut the cord.
Babies are placed straight on their mothers when they're born to help with bonding and attachment.
So there only you have to
skin is the best way
warmth
to
and
keep
dry.
babies at a perfect temperature, and it will encourage baby Deanna Lee to try her first taste of breast milk. Lindsay went into labour earlier this evening, and her second son Ben was born half an hour after arriving at the hospital.
So you have to put the baby on the mother's chest. If the baby cries at birth, you have to put the baby on mother's chest. So that is called skin to skin contact. Okay. And there only you have to delay the cord clamping by at least 30 seconds. Okay. So, and then you have to warm the baby and dry the baby there only on the mother's abdomen. That is called routine care. What is that called? Routine care. Okay. So we will go to the next chapter questions. So what are the 4 pre-birth questions you have to ask to whom you have to ask? You have to ask your obstetric care provider. So what are the 4 pre-birth questions? It is, what is the gestation of the baby? What is the amniotic fluid color? Okay. And then what is our cord management plan? And then what is the 4th question? What you have to ask? What are the other risk factors? You have to ask is risk factors, not number of babies. Okay. So you can make your own mnemonic. Okay. GARU or something. Gestational age, amniotic fluid color, risk factors, and umbilical cord management plan. So these are the 4 pre-birth questions you have to ask. Next, every delivery should be attended by at least one qualified person whose only responsibility is management of newborn. Okay, so there should be not a nurse who takes care of both mother and the baby. No, there should be only a person whose only responsibility is to take care of the newborn only. There should be no multitasking. Okay, high risk and birth is anticipated. You always need a qualified team. Okay, so always you need a qualified team. So next, these things are not very much important. The other questions. So 4 pre-birth questions are gestational age, amniotic fluid, additional risk factors, and what is our cord management plan. Okay. When every delivery should be attended by one person whose responsibility is only the management of newborn. There should be no shared responsibility with mother care or anything else. Okay. But if high risk birth is anticipated, you need a qualified team always. So these questions are not very important in this chapter. So then straight away move to the next initial steps. Okay. So what are the initial steps? What are the 5 steps in the initial steps part? Can you type what are the 5 initial steps? So as I already told, warmth, dry, stimulate, position head and neck to open the airway, and secretions. Okay. WDSAC, whatever mnemonic you want to make yourself, you have to think. So there are 5 initial steps. Okay. So umbilical cord should be delayed by 30 to 60 seconds. Okay. So when you should delay, when the baby is term, tone, breathing, or crying. If the answer to all these questions are no, then you have to just leave with the mother. Term, tone, breathing, or crying. If the answer is yes for all these questions, then you have to do delayed cord clamping of 30 to 60 seconds and leave the baby with the mother. Just you do routine care. Okay. And then you have to attach the pulse oximetry there only to the mother, on the mother's chest only. You have to attach to the right upper limb. Where you should attach the pulse oximetry? Always right upper limb. Unless the baby has no right upper limb, there is no other option. You have to attach the pulse oximetry to the right upper limb only. Okay. So some of the questions we will do. So these are the initial steps. You should never miss any word in these. Provide warmth, dry, stimulate, position head and neck for airway, and clear secretions. Okay. So this is how the initial steps is done. So baby is placed on the mother's abdomen. So here only you are doing the provide warmth, everything. Then drying on, you have to put another towel, you will dry the baby. And if the stimulation is required, you can do there only. Okay. So correct sniffing position. So we'll go with the next question. So what is this? What is this situation? It is acrocyanosis. You can see the center of the baby is pink and periphery is blue. So this is normal in a just born baby. This is normal. Acrocyanosis is normal. Okay. So only you have to give oxygen if the saturation target is less than that minute. Okay. Otherwise, acrocyanosis is normal for initial few minutes. If you see any acrocyanosis baby, you just put an oxygen saturation probe. Okay. Then check the saturation for what is the saturation at that minute. If that minute saturation is not matching to your chart, then you give oxygen. Otherwise, you just monitor the baby, warm the baby, then it will be fine in few minutes. Okay. So always put the pulse oximeter to the baby's right hand. Okay. Right hand always on the hypothenar eminence is better rather than wrist. It is always better to put here. You will, because the vessels are very thin, you will pick up the saturation very early. Okay. So always put the baby saturation on right upper limb. So these are the target saturation. 5 minutes we had asked. 5 minutes is 80. Usually they will ask 5 minutes only. Nobody will ask 4 minutes or anything. So 10 minutes you can easily remember. 5 minutes and 4 minutes you can remember. If they want to test you routinely, what they ask from the time I am writing exam, it is usually 5 minutes only. 5 minutes, 80 to 85%. So there should be some 5. You should always remember every option there should be some 5. So these are the ways of giving. So you should never give oxygen with your ambu bag. Ambu bag only from behind you can give. So what is this device? Can you someone name this device? What is this device? What is this device? Can somebody type it? What is this device? What we are doing here? This is air. This is oxygen. Okay. This is air. This is oxygen. What are we doing here? Mixing. What is it called? Mixing. What is the device that mixes air and oxygen called? What is this device? Can somebody type here? Zara, can you name this? There are 5 letters are already given here. This is oxygen, air oxygen blender. Okay, the blender, air oxygen blender. Okay. So you have to adjust the concentration of FiO2. This is what should be used in labor room usually if the baby is less than 35 weeks. So no, it's not blendy, it is blender. Okay. So if the gestation age of the baby is more than 35 weeks, we have to start at 21% only. Okay. If the baby is less than 35 weeks, then we have to start between 21 to 30%. 21 to 30%. Then only you have to match the oxygen target, the chart we have to use. Okay. There will be 2 air source, oxygen source. This center machine, it will blend. So what are the 3 rapid questions that has to be asked at newborn when the baby is brought to the radiant warmer? So what are and should be brought to the radiant warmer? Okay. What are the 3 questions you ask after birth? What are the 3 questions that you ask? It is term, tone, breathing or crying. Okay. Term, tone, breathing or crying. So what are the 5 initial steps? Provide warmth. Okay. WD, dry, stimulate, position head and neck to open airway, and clear secretions only if necessary. Each word is very, very important. These are the only things they will ask. Okay. So WD, SPS, whatever mnemonic you want, it is comfortable to you, you make. You do not follow any. Warm, dry, stimulate, position airway, and secretions. Suction only if necessary. Clear secretion. Whatever mnemonic you want, you can make. So oxygen saturation, should you count a newborn's heartbeat for 6 seconds and count the beat as 6. So what is your heart rate of the baby? So it is 60 per minute. Okay. So it is 6 times 60. Okay. So what is the oxygen saturation? When will the 85 to 95 will reach? So it is at 10 minutes of age. Okay. So at 10 minutes, your oxygen saturation will reach at 85 to 95%. Okay. So which image shows the correct position of the baby's head to open the airway? So which do you think among A, B, and C? So which one do you think is the correct position? Correct position is called sniffing position. Okay. No, it is wrong. A is not the answer. B is the answer. A is too much extended. Okay. A is too much extended. B is too much flexed. So this is the correct sniffing position. Okay. It should be just less like when you go for morning walk, you just smell something good and you feel the smell. So some good smell you smell, just like just a slight extending the neck, the slight extending. This is hyperextension. Okay. Okay. Next question is, you provide warmth, dried, stimulated, positioned the head and neck, and you cleared the air secretions. So you have done initial steps. So now it is 60 seconds after birth. So baby is still limp and apneic. So what do you want to do next? So what is your next step of action? So you have provided initial steps. After initial steps, you will ask two questions. That is heart rate less than 100 and baby is limp, apneic or gasping. Okay. So here they have given apneic or gasping. So what is your next step? If the baby is not apneic or gasping, heart rate is more not less than 100, then you ask two questions more. Okay. So that is labored breathing or cyanosis. Here you have got the answer. Next, what you will do? What you will do next? Here, the algorithm. So you have done warm, dry, stimulate, position airway, suction. You have done everything. After that, baby is apneic or gasping. What you will do next? So you have to give your positive pressure ventilation. Huh? So you have to go ahead with bag and mask or positive pressure ventilation. Okay. If, for example, if the baby is not apneic or gasping, if the heart rate is also not less than 100, then you ask two questions: labored breathing or persistent cyanosis. If anything is this, yes, then you have to give CPAP or oxygen. If there is persistent cyanosis or labored breathing, CPAP, persistent cyanosis, you give oxygen. If there is only acrocyanosis, you just attach oximeter and then monitor this table. Okay. If there is only acrocyanosis. So you got to know. Okay. Next question. So if the baby is breathing, now the heart rate is greater than 100 beats per minute, airway is clear and the baby is correctly positioned, but the respirations are labored. So what do you want to do now? So everything 100, it is more than 100 and it is baby is breathing also. You have positioned the head. Okay, now the baby is having labored breathing. So what you want to do for labored breathing baby? Whether you want to do deep suction again or you want to start with CPAP. So you can see this. Huh? There is labored breathing, persistent cyanosis. You have done positioning airway and suction you have already done. So you have to consider a CPAP. Okay. Labored breathing or persistent cyanosis. Labored breathing, you have to go with CPAP. Persistent cyanosis, you may just need oxygen. Okay. So you may have to consider CPAP. And if you have to start, previous question, you have to start on positive pressure ventilation, then you have to call for additional help. If you are alone, you have to call for additional help. If you are in a group, it is fine. Huh? So you got to know. Okay. So this is okay. And then we'll finish soon. So positive pressure ventilation. So they may give you these ambu. They may ask you this valve, which you don't usually see in your routine hospital ambu. Okay. This is your PEEP valve. PEEP valve. Huh? This is your pressure gauge, whatever you get. We'll discuss it again. Okay. So this ambu they may show you, and this entire thing is patient end. This is your oxygen and reservoir end. Okay. Here you put oxygen, here you put reservoir. Here there will be a gauge and pop-off valve. Here you will attach to the patient. They will ask usually, what is this end, this green color cap? This will not be in ambu, whatever we use routinely in our hospitals. This ambu is very costly, so they won't try to get it here. So this is a PEEP valve. Normally it won't be there. PEEP. Normally these ambu bags will not be giving PEEP, only PIP. When you press this, PIP. Okay. This valve is very special. Okay. PEEP valve. This is how to test the ambu. This is a pressure gauge. This is your pop-off valve. If the pressure goes above 40, it will open up so that you don't give more pressure to this, to the baby. So this is also called self-inflating bag. So this is a technical term. So usually 30 to 40 centimeter of water, this will open up. The pop-off valve will open up. That is the maximum required for the baby. This is your flow inflating bag. Whatever you see in your OT, anesthesia fellow will be holding. This is your flow inflating bag. This will open up only when there is a flow, adequate flow is coming. Then only this will, and only tight seal is there. Then only this will get inflated. If there is leak, it will not get inflated. What is this device called? Can you name this device? Can somebody name this device? What is this device called? This device can be asked in your exam. What is this device? So this is T-piece resuscitator, infant T-piece resuscitator. Okay. So there will be a T-piece like this. So this you can, instead of ambu bag and everything, you can, this is a sophisticated this is almost like a mini ventilator, hand operated mini ventilator like thing. So this is a T-piece resuscitator. T-piece resuscitator. Don't go much into detail. So if you want a shoulder roll, you can use shoulder roll. It should not be too much extended. This is your round mask and anatomical mask. So mask should not cover chin. Should not cover till chin. Should not be covering your eyes. You should not cover your eyes. So this is again a blender. You should not forget this. Air and oxygen mixing is blender. 5 minutes, 80 to 85. 10 minutes, 85 to 95%. Less than 35 weeks, 21%. More than 35 weeks, 21% oxygen. Less than 35 weeks, 21 to 30% oxygen. Okay. So can solve some question. MR SOPA, they may ask you what is mask, MR, what is SO, and what is P, and what is A. MR is mask adjustment. You have to just remove the mask and adjust again. Okay. So R is reposition the head and neck. If the head is extended or is slightly extended, you can just place the head neutral. And you have to suction, then again give 5 breaths and assess. If it is not there, then do S and O. Suction the mouth and nose and open the mouth. Okay, 2 things at a time. Once you have done 4 things, then again every time you give 5 breaths and then you do it next again assess. Then you increase the pressure, whatever you are doing, just give more pressure till 30 to 40. Okay, again give 5 breaths. If everything is not happening, then you have to go for alternate airway. Alternate airway is laryngeal mask airway or endotracheal intubation. So these are your laryngeal mask airways. So you cannot use less than 34 weeks and less than 1.5 kgs you cannot use. Okay. So these are your laryngeal mask airway. So how do you measure OG tube? I think this was asked in one of your current questions, I think. So you have to measure the distance from bridge of the nose. Okay. Bridge of the nose to the ear lobe, and from ear lobe to the midpoint. Okay. Midpoint between the umbilicus and the xiphisternum. Okay. This is the midpoint between umbilicus and the xiphisternum. From here it is ear lobe. From ear lobe to the bridge of the nose. Okay, so this is the correct way to measure the NG tube or OG tube. So we can have some questions like this. Okay, what is the single most important step in neonatal resuscitation? Whether it is stimulation or ventilation of lungs. So we already know it is ventilation of lungs. Ventilation of lungs is the single most important step. Okay. So after the initial steps, positive pressure ventilation is indicated. When you do the positive pressure ventilation, if the baby is apneic or gasping, these are 2 things, or if the heart rate is less than 100 beats per minute. So these are the 2 things. Apneic or gasping, or heart rate is less than 100 beats per minute. So now a baby is born limp and apneic. You place the baby under the radiant warmer. You are doing initial steps. You are warmer, dry, stimulate, position, and then suctioning. So now it is already 60 seconds and baby is still apneic or gasping. So what you will do now, whether you want to stimulate more or you want to begin positive pressure ventilation. So it is 60 seconds. By 60 seconds, you should begin your positive pressure ventilation. Okay. So you should begin. Correct answer. Huh? Zara, you are getting it right. So for positive pressure ventilation, you should adjust the flow meter to 10 liters per minute. Okay. This and all you will not remember. Administer 40 positive pressure ventilation. It is 40 to 60 breaths per minute. How many times you have to do Ambu? 40 to 60 times per minute. So begin pressure with 20 to 25 centimeter, go up to 30 to 40. Ventilation in the term baby, what oxygen you have to start with? You have to start with 21% oxygen. Very good. So if you are using a device that administers PEEP, what is the initial pressure? You have to start with 5. PEEP, always 5. This is what we are talking with positive pressure ventilation, PIP. That is PIP. It is 20 to 25. So now you have started positive pressure ventilation and you are giving rate 40 to 40 breaths per minute and your heart rate is not improving. Heart rate is 40 only. So after positive pressure ventilation, your heart rate is not improving. There is no chest movement also. What you should do, whether you should go ahead with chest compression or whether you should start with ventilation corrective steps. So you should always go with ventilation corrective steps. Okay. Don't jump away that heart rate is less than 60. You don't jump away with chest compression. Okay. So you always, if your chest is not moving, then you have to do ventilation corrective steps. Then only you go for chest compression. Okay. So what is that? Yesterday we had seen the equipment, end-tidal calorimetry. So inflation and deflation of the lungs, which is suggested by CO2 detector. So what color does it change to? It is yellow color. Normally it will be purple color. If it changes to yellow color, it means that there is correct aeration of lung. No, it is not purple. It is normally it is purple. Okay. Normally it is purple. So if it has to turn yellow, that has to turn yellow. Normal color of it is purple only. In room air also it is purple. Only when the CO2 comes, it will change to yellow. So now, so you have started positive pressure ventilation. The heart rate has remained 40 beats per minute, despite performing all ventilation corrective steps and ventilating through an endotracheal tube also you have done for 30 seconds. Now your assistant sees chest movement with positive pressure ventilation. So now what you should do? Your assistant sees chest movement with positive pressure ventilation. So what you should do now? You have started a positive pressure ventilation. Heart rate has remained 40. You have done all corrective steps. You have even intubated the baby also. So after that also, chest movement is there, but still the heart rate is less than 60. So what you will do now? One time it is less than 60. What you will do? You will go with, no. Chest compression. You have to proceed to chest compression. You are already ventilating the baby. You should not increase the rate. Rate should be always 40 to 60 only. You don't increase just because the baby's heart rate is less. You don't increase the rate to 100 beats per minute. Should be very careful. So laryngeal mask, when you insert a laryngeal mask into baby's mouth and advance it to the throat until whether it should cross the vocal cord or it should seal at the entrance of the baby's trachea. So laryngeal mask airway will not go into the vocal cords, through the vocal cord. It will just make a seal. It is a mask to the larynx. So it will just make a seal over the entrance of the baby's trachea. Okay. So it will not cross the vocal cord. So next, how will you measure the orogastic tube? So if you measure the orogastic tube, you measure the distance from where do you measure? Bridge of the nose to the earlobe, and from the earlobe to where? To the nipple, or whether it is to the point halfway between the xiphoid process and umbilicus. It is not to the xiphoid, not to the umbilicus. It is midpoint between the xiphoid and the umbilicus. From bridge of the nose to the earlobe. From earlobe to the midpoint between the xiphoid process and umbilicus. Okay. So this is how you measure the NG tube. You understanding? Getting any use from it? So now you can see the. Now you can see the parts. So what is the two? What I told you. What is this two? This is the most important difficult thing. What is this two part? As I told you, this is the most important thing you don't know. 2 is your PEEP valve. Here it is all wrong. It is given the ABCD is not PEEP valve. Okay. So what is 3? 3 is your manometer. How much pressure is going? It is manometer. 4 is pressure release valve or pop-off valve. Okay. 4 is pop-off valve. And what is this thing? Here, what is this entire thing? 8-1 is called, it is called valve assembly. This is here. Entire, there will be so many valves here. Valve assembly. Okay. And this is oxygen reservoir. This is oxygen reservoir. This is oxygen source, and this is oxygen tubing, gas tubing. This and all is wrong. Given alphabets are wrong. This is what we see usually in our ward and all. There is no PEEP valve only. This is our routine ward AMBU. You don't get this PEEP valve only. Be careful with this PEEP valve. So this and all is not required. So this is your flow inflating bag. Okay. This is your flow inflating bag. It is almost same. The 4 is, this is one thing you can miss. And 3 is also very important. This is your gas inlet here. Okay. Here you connect the gas in at the here in between your bag and the patient end. This is where you connect the gas. Whereas in your self-inflating bag, you connect at the bottom. This is again manometer. And next is this valve controls the flow, how much oxygen should go. Okay. You need not worry about all these things much. So this is TP's resuscitator. You need not worry much about the parts. So what is important in TP's resuscitator is again here, not in the machine part where you attach to the patient. Okay. This is very important. This is PEEP adjusting dial. Here you adjust the PEEP. PEEP, you adjust it here. So can have some more questions, some more scenarios. You have to revise it again and again so that you will get used to it. So endotracheal intubation, you have to just every figure speaks something. You have to always hold the laryngoscope with your left arm. Okay. To always hold the laryngoscope in your left arm. Whether you are right-handed person or left-handed person, you have to always hold the laryngoscope in your left arm. So here they have placed the pulse oximeter on the wrist, but it should not be wrist. It should be hypothenar eminence. So intubation, most important thing is when it should be completed. After you should take how many seconds to complete intubation. So it is usually 30 seconds. Okay. So if anybody is not able to intubate within 30 seconds, you should call another person who is expert into it. So that question is also frequently asked in your thing. So only 3 size endotracheal tubes, 2.5, 3, 3.5, and straight size laryngoscope blade, straight blade. So what are the things you see when you do a laryngoscopic view? What you see is vocal cord. The opening between the vocal cord is glottis. Okay. Tongue, spelling is wrong. It is tongue. The most anterior most thing structure, what you see, what you put the laryngoscope on is your tongue. You have to lift the tongue above. You should not liver the tongue, liver the laryngoscope over the teeth. You should lift the tongue up. And then where your laryngoscope blade should place, it should be in the vallecula. Okay. So your laryngoscope blade should be in the vallecula. You should not lift the epiglottis. Epiglottis should be lying there only. Okay. You should not lift the epiglottis. You should lift the tongue, base of the tongue, so that laryngoscope blade is in the vallecula. Okay. So, and then what you see is vocal cords. The most downwardmost structure, what you see is esophagus. Topmost structure, what you see is the tongue. Okay, this is how you see whenever you are intubating. These are the structures what you see. So these are the equipments for intubation. So there will be vocal cord guide in all ET tubes, but you should, this is not a good indicator for intubation. Okay, you should always have a ready-made chart. Okay, what size ET tube you should have a ready-made chart, and where you should insert the depth. Should have a ready-made chart. Where you, how you should hold the laryngoscope, always in your left hand with thumb resting on the upper surface of the laryngoscope handle. Okay, this thumb should be like this. So both left-handers and right-handers, they should use in, okay, they should use in left hand only, because if you hold in the right hand, the curvature portion will be obstructed. Okay, the curved portion of the blade will be obstructed. So see, this is how the thing goes. You are lifting the tongue. Where you are placing the laryngoscope blade, the tip of the laryngoscope blade is in the vallecula. You should not forget this. The tip of the laryngoscope blade should be in the vallecula. And then you should pull the tube like this. This is the correct way. You should pull the tongue in this direction. You should not lever like this. This leverage is wrong. This will cause trauma to the upper incisors. You will break the upper incisors. Okay, if you push the tube, push the laryngoscope blade backwards to lift it, it should not be. Your movement should be in this direction. So as I told, laryngoscope blade is in the vallecula. It is the base, it is lifting the base of the tongue. What you see is epiglottis, glottis, two vocal cords, and posterior most structure is your esophagus. Okay. So this is how the structure, what are the structures you see. So here laryngoscope blade is still further up only. Okay, the laryngoscope blade, if you are very too far, you will go into the esophagus only. Okay, if you go into the esophagus, or you will be lifting the epiglottis only. That should not cause. So see, still you are seeing some of the tongue. Here you are seeing the esophagus. So this is all wrong. So how much time should be allowed for intubation attempt? 30 seconds. Within 30 seconds, you should complete intubation. See here, they have intubated and it has turned yellow. Can you see this end-tidal calorimetry or CO2 detector? Okay, so we have attached to the tube and it has turned yellow. So it shows that it is properly in the trachea and properly ventilating. Okay, see here it is still purple. So what does it mean if it is purple? So detector turns yellow in presence of exhaled carbon dioxide. Okay, normally it will be purple. If there is carbon dioxide is detected, it will turn yellow. How many breaths are required? At least 8 to 10 breaths are required before you interpret this. Okay. So how do you check the depth of intubation? It is nasotracheal length. Okay. So nasal septum and tracheal length. It is not bridge of the nose is for OG tube. OG tube. Here it is ET tube depth. ET tube depth is. So you have to remember the diagram, then only you will be able to remember things. Then you have to use the ready-made chart that is available. For each gestation and weight, there is a chart given. This chart should be used. You need not by heart any of these things. Okay. So always use end-tidal calorimetry. See here, if you have intubated the tube more in the right side, okay, the tip of the tube is indicated too far and it is touching the carina, so it is in the right mainstem bronchus. So that's why left side is not at all getting ventilated, so it is collapsed. Okay. So what is dope? Dope is mnemonic for displacement, obstruction of endotracheal tube, pneumothorax, and equipment failure. So this is, you have to, this is a mnemonic you have to see if the patient is on ventilator and there is sudden deterioration. If the patient suddenly deteriorates after intubation, you have to use dope. When you are using bag and mask, you have to do MR SOPA. Okay. So now a newborn has been receiving bag and mask ventilation but is not improving. Despite performing first ventilation corrective steps, heart rate is not rising and there is poor chest movement. Alternate airway, such as endotracheal tube or laryngeal mask, whether it should be inserted immediately or you should take time. So it should be inserted immediately. After the 5 correction steps, you have to go for alternate airway. So for less than 1 kg, what size tube is recommended? 2.5 size tube. Okay. If you are using a stylet to put endotracheal tube, the tip of the stylet must not extend beyond the ET tube side holes because it will cause trauma to the trachea. Okay. So preferred laryngoscope to be used in term babies is, what is the preferred laryngoscope? Term babies is 1 size. Okay. So which is the epiglottis in this diagram? Can you name the epiglottis? Which is the epiglottis? So epiglottis is A. Okay. So that is right. So you should try to take no longer than how many seconds for endotracheal intubation? How many seconds maximum it is allowed? Okay, 30 seconds. That is correct. So if the baby's condition worsens after endotracheal intubation, what are the 4 causes? As I told, dope, displacement, dope, D-O-P, dope. Displacement, obstruction, pneumothorax, and then what is another E? Is equipment failure, not extubation. Okay, they may write it as E for extubation. You should be very careful. Displacement, when you write obstruction, no, displacement, obstruction, pneumothorax, the most thing most people go is extubation. So it is not E for extubation, it is E for equipment failure. Your equipment, whatever ambu bag you are using or ventilator you are giving, it might have been not functioning well. This also you should okay. So which image shows the correct way to lift the tongue out of the way and expose larynx? Which is the correct option, A or B? It is A. Okay, so you should not lever the laryngoscope. Okay, you should push the tongue forward. Okay, so you have inserted an endotracheal tube and you are giving a positive pressure ventilation. The CO2 detector does not change color and baby's heart rate is decreasing. It means that where is the tube? It is in esophagus. So it purple color, it should change to yellow color. Okay. So what are the 2 most important indicators that endotracheal tube has been inserted in trachea? Are demonstrating exhaled what? Exhaled CO2. Okay. Exhaled carbon dioxide, and there is rapidly increasing. What will increase if the tube is in the trachea? What will increase in the baby? Why we are intubating the baby? Because heart rate is not improving. So once you put inside that exactly correctly inside the trachea, your heart rate will improve. Okay. So now you have inserted the laryngoscope and you are attempting intubation. So you see this picture depicted in the illustration. What is the correct thing? Whether you are to insert the laryngoscope further or you are to withdraw the laryngoscope. So this is still the base of the tongue is coming in your view. So you have to advance the laryngoscope further. Okay. Advance the laryngoscope further. Okay. So we'll finish with the chest compression. So as I told you, chest compression is begin when there is less than 60 beats per minute. After at least 30 seconds of positive pressure ventilation, with that inflates chest. Okay. When your chest is moving, then only after 30 seconds, if the chest is moving, then only you have to go for chest compression. Otherwise, you're not going for a proper ventilation. You're not at all giving a proper ventilation. So this is how you have to remember each thing. Okay. 2 thumb technique. They have to encircle. Then you have to change the reservoir to 100%. Okay. And then you have to intubate. These are the 4 things that has to be done when you are doing a chest compression. Where you have to do chest compression? At the lower one third of the sternum. Internipple line, below the internipple line is your lower 1/3 of sternum. Okay. So below the internipple line in the lower 1/3 of sternum is where you have to do chest compression. Okay. So do not place the ribs and do not place the hands on your ribs or xiphoid. It will break. So how much compression and chest compression and ventilation you have to give? This also question may come. It is 3:1 ratio. Okay. So there are 3 compressions and 1 ventilation for every 2 seconds. So this whole thing can come as an option for you. Okay. So 3 compression, 1 ventilation for every 2 seconds. There should be no confusion. Okay. They may give you 2 compression, 1 ventilation for every 3 seconds. They may jumble up and give anything. So just give 3 rapid compression, 3 compression and 1 ventilation. Okay. 1, 2, 3, you have to squeeze. 1, 2, 3, squeeze. 1, 2, 3, squeeze. So total events per minute is 120 events. Okay. So 90 chest compression. They may ask you anything. The question may come anything. Whether full minute they may ask 90 chest compression, 30 ventilation. That is 120 events per minute, or may even 2 seconds also they may give any question. Okay. They may shift anything. So these are some of the questions. So these are very interesting questions in this part. There are very 8 questions we will solve. So a newborn is apneic at birth. The baby does not improve with your initial steps. So you have failed your initial steps. You have started positive pressure ventilation. So after 30 seconds of positive pressure ventilation, the heart rate has increased from 40 to 80 breaths per minute. So you are given positive pressure ventilation. The heart rate has increased from 40 to 80 breaths per minute. So what you should do now? Whether you should chest compression should be started, positive pressure ventilation should be continued. What we should know? What do you want to do now? No, it is not PEEP. Positive pressure ventilation. Positive pressure ventilation should be continued. You should not start with chest compression. Okay. So should not start with chest compression because it is not less than 60. It has improved. So you continue with your positive pressure ventilation. Okay. So again, a newborn is apneic at birth. Baby does not improve with your initial steps. Endotracheal tube is inserted. The chest moves with ventilation and bilateral breath sounds are present and ventilation is continued for another 30 seconds. The heart rate is still less than 40 per minute. So here the heart rate is still less than 40. Still less than 60, that is 40 beats per minute. So what you should do now? Whether you should do with chest compression. So chest compression should be started. And you should not just only do chest compression, you should also continue with positive pressure ventilation. Okay. Both chest compression and positive pressure ventilation. That is by intubating. By intubating, you are doing AMBU, that is itself is positive pressure ventilation. Okay. So where you should do your chest compression, A, B, or C. So just below the internipple line. Okay. Just below the internipple line where you have to do chest compression. Okay. What is the correct depth of chest compression? 1/4, 1/3, 1/2, or 2 inches. So it is 1/3 of the anteroposterior diameter. Okay. So what is your ratio? So what is the ratio of chest compression to ventilation? It is 3 compression to 1 ventilation or 1 compression to 3 ventilation. So it is 3 compression. 3 compression. 3 comes with C. You just remember that. 3 compression, 1 ventilation. Okay. So which phrase we use to achieve correct rhythm? That is breathe 2, 3. So 1 and 2 and 3 and breathe in. So this is the rhythm which it is not very important for you. So breathe 2, 3 is your bag and mask ventilation. So here is your 1 and 2 and 3 and breath and 1 and 2 and 3 and breath. And so that's why you would make 4 events in 2 seconds. So that is not important for you. It's not important for your exam. So once you are doing chest compression, you should briefly stop to check the baby's heart rate after how many seconds? It is 60 seconds. Okay. After you are doing chest compression, only after 60 seconds you have to assess. If it is still less than 60, what you will do? If it is still less than 60, after 60 seconds of chest compression, if it is still 60, 2 times less than 60, what we told? Epinephrine, yes. If it is 3 times less than 60, what you will do? If it is still less than 60 after 3 times, you have to give bolus and consider pneumothorax. Okay. So chest compression should be discontinued when heart rate is greater than 100 beats per minute. If it is more than 100, then more than 60 beats per minute, you have to just stop chest compression. If you have to stop positive pressure ventilation, if the heart rate is more than 100. Okay, this is not 100, this is 60 beats per minute. Okay, so these are the only things. Only thing is medication. This is very simple. Only medication what we use in resuscitation is your adrenaline. Only we have to use is adrenaline. So what concentration we get adrenaline? 1 in 1000 we get. We have to make it to 1 in 10,000. Okay. So what are the 2 routes that are advised? Only is intravenous or intraosseous. Only if it is endotracheal, then we have to give. If it is not available, only the intraosseous or intravenous is not available. So we have to give. How much is the dose? 0.02 mg per kg or 0.2 ml per kg. Okay. Then followed by flush. Flush is 3 to 5 ml. 3 ml. Sorry, 3 ml. It is. There should be no confusion with what flush. So endotracheal, how much we have to give? It is 1 ml per kg. It is almost 5 times. Okay. Endotracheal dose is 5 times. How much, what we have to use for volume resuscitation? Either NS or O negative blood. Okay. O negative blood or NS can be given according to NRP. Okay. So how much we have to give? 10 ml per kg. How much rate? Over 5 to 10 minutes. Okay. So when we have to stop resuscitation? 20 minutes. If there is no heart rate, no breathing efforts after 20 minutes after birth, we should continue up till 20 minutes. Then you have to discontinue only after speaking to the parents. Okay. So this is how you give adrenaline. Okay. Here you have to use always a T-piece, 3-way stopcock. You have to push the adrenaline, then turn the stopcock, then give the push. So this is how it has to be given. Okay. Just like you give adenosine, that's like that you have to give. So this is the last questions we can do for today. Okay. So what are the volume expanders? Only 2 things, NS and O negative PRX. What is this only drug that can be used in resuscitation? Epinephrine. Okay. So this is how you establish the umbilical line, either umbilical line or peripheral line you can use. So this is the intraosseous needle. This is one of the intraosseous needle. If they ask this diagram, if they give this gun and they show you this needle, what they are doing is insert intraosseous needle drill. Okay, this is a drill to put intraosseous needle. Okay, you prepare the area and you put an intraosseous needle. So these are some of the questions. So ventilation that moves the chest has been performed through an endotracheal tube for 30 seconds, followed by coordinated chest compression and 100% oxygen for additional 60 seconds. So when do you give epinephrine? If heart rate is less than 60 or less than 80, so it is again less than 60. Okay. Preferred route of epinephrine is intravenous. If it is intravenous is not there, intraosseous. If intraosseous is also not there, then only you go for intratracheal. Okay. So now your team is resuscitating a baby born at term. The baby's heart rate is 40 beats per minute. After 30 seconds of ventilation through endotracheal tube and additional 60 seconds with coordinated chest compression and ventilation using 100% oxygen. You determine that epinephrine is indicated. Your team should, what you should do, should quickly insert a peripheral catheter or you should insert an umbilical venous catheter. So easiest is insert an umbilical venous catheter. Okay. So that should be your next step. Insert an umbilical venous catheter to give epinephrine. If you are not able to insert umbilical venous catheter, intraosseous. If you're not intraosseous, it is endotracheal. So what is the recommended concentration of epinephrine for newborns? It is 0.1 mg per ml. It is irrespective whether you are giving endotracheal or intraosseous or intravenous. This is the standard strength you have to use, 0.1 mg per ml. 1 mg per ml, you have to dilute to 10 ml, that is 0.1 mg per ml. What is the suggested dose? It is 0.02 mg per kg. Okay. How much flush we have to give? As quickly as possible, 3 ml flush. Okay. How frequently we have to repeat epinephrine? 3 to 5 minutes. Okay. What is the volume expander dose? 10 ml per kg, that is NS or your O negative whole blood. Okay, it is not O negative PRBC, O negative whole blood. Okay, so this is all you can ask for you people. Don't worry about the preterm and all. These are the only things that can be asked for you people. Okay, so any doubts you want to ask?